Rusty with a very interesting approach. I'll ask Professor Jang from Harvard Medical School, who has done a study on effective antithrombotic therapy without stenting.
Good morning, Mr. Chairman, ladies and gentlemen. I'm Ik-Kyung Jang from Massachusetts General Hospital, Harvard Medical School. This study was in collaboration with Professor Bowie, Harvard Medical University in China. We decided to change the title a little bit, Effective Anti-Thrombotic Therapy Without Stenting, Intravascular OCT-Based Management in Plaque Erosion, the Erosion study. This is personal conflict of interest. This study was funded by AstraZeneca China. The study was done in Hardin, but the concept, protocol, and analysis were done in Boston. So there are 3 underlying pathologies for patients with sudden cardiac death and acute coronary syndromes, including ST elevation MI, which include rupture, erosion, and calcific nodule. Plaque rupture has been well characterized both in patients and in autopsy studies. Plaque erosion, on the other hand, has never been characterized in patients. With the introduction of optical coherence tomography, OCT, we thought it might be possible to make a diagnosis of plaque erosion in living patients. These are the representative images from patients. The left shows plaque rupture. So this used to be covered by necrotic core and fibrous cap, now disrupted. This is erosion, and this is calcific nodule. As you see here, there are distinct differences in morphologic characteristics between rupture and erosion. Compared to rupture, erosion has preserved vascular integrity, larger lumen, and these are platelets. So we hypothesized patients with plaque erosion may be stabilized by effective anti-thrombotic treatment without stent implantation, thereby avoiding both early and late complications related to stent. So patients with acute coronary syndrome were treated with aspirin, ticagrelor, and heparin prior to catheterization. Glycoprotein 2B3 inhibitor and aspiration thrombectomy were at the discretion of the treating cardiologist, and heparin was continued for 3 additional days. The combination of aspirin and ticagrelor was continued until the follow-up study, and OCT was repeated after 1 month. So this is the summary slide showing the prevalence of plaque erosion. It was 25.4%. So 1 out of 4 patients coming with acute coronary syndrome or acute MI, underlying pathology is plaque erosion. So this is a key slide. The median thrombus volume, the primary endpoint was more than 50% reduction in thrombus volume, which we can measure with OCT. So this median thrombus volume dropped from 3.7 to 0.2, and minimal flow area increased from 1.7 to 2.1. So this is a bit busy slide. So these are the patients at baseline and 1 month follow-up thrombus volume. When we exclude these 8 patients with significant reduction and zoomed up the rest of the patient, you still see pretty consistent reduction in thrombus volume, except 1 patient which didn't show any reduction, and additional 7 patients or so who showed relatively minimal reduction. As I mentioned, the primary endpoint was more than 50% reduction in thrombus volume. So we put the 50% line, and the rest here, anybody with a circle below this dotted line met the primary endpoint. So with the intention to treat analysis, 47 out of 60 patients, 78% met the primary endpoint. And among them, 22 patients, all these bottom circles, had no residual thrombus. So thrombus completely disappeared. So roughly 34%. If you use the real actual number of patients who underwent follow-up OCT, the primary endpoint goes up to above 80%, and 40% had zero residual thrombus. This is a representative case of 65-year-old patient with anterior STEMI. At the time of presentation, as you see here, this is a cross-section OCT image, catheter vessel, and these are platelets, platelet-rich thrombus. And after 1 month treatment of aspirin and ticagrelor, thrombus has completely disappeared, and minimal flow area increased from 2.4 to 4.0. So we conclude plaque erosion was the underlying pathology in 1 out of 4 patients with acute coronary syndrome. Anti-thrombotic therapy with aspirin and ticagrelor without stent implantation effectively reduced thrombus volume and increased flow area without recurrent ischemic event at 1 month. And randomized trials will be needed to reproduce this pilot data and to further evaluate long-term outcome of this new treatment strategy in patients with ACS caused by plaque erosion. Thank you very much.
Excellent. So this is work that follows on previous work that purely identified patients that we thought we can get away without a stent on angiographic grounds. This adds more information and more sophistication to the identification of patients that may not need a stent. And you say 25% out of the ones that qualified for this study. This is very interesting and generates, of course, probably a clinical trial. Are you on the road to do a trial with clinical endpoints?
Obviously, we are thinking about the next step study, which will require a large number of patients.
Questions?
We're open for questions.
Yes,
first
please.
row. Third row.
Yeah, okay. Start there, then you back.
Yes, please.
Yes.
Okay, Nicole Liu for MedPage today. I'm wondering how feasible it would be to start this treatment like tomorrow, say if clinicians were so interested. I guess what I'm referring to is the use of OCT and the availability. Is there enough OCT that doctors would be able to start doing this right away?
So you can think about 2 different categories of patients. So ST elevation MI, they all come to the cath lab. In the United States, most hospitals with capability of primary angioplasty, I believe they have OCT. It may not be easy for those people with too much experience with OCT to interpret erosion, but in collaboration with MIT, Massachusetts Institute of Technology, where OCT was developed, we have developed computer-aided diagnostic algorithm. So with 2.5 millimeter second pullback, you can identify areas of erosion with probability of 80%. So it should not be too difficult to make a diagnosis of erosion and treat this patient. But I should emphasize this study was the so-called proof of concept study, pilot study, just to test our hypothesis. And we were surprised actually with the result, dramatic effect. So that's the ST elevation MI. And the other category is non-ST elevation MI, patients who are a bit more stable. And it is our hope to identify those patients with acute coronary syndrome caused by plaque erosion upfront, so that eventually avoid a trip to cardiac catheterization and triage those patients to more conservative management strategy.
First row.
Hi, I'm Mike Reardon with TCTMD. I think my question might be a bit redundant. I was just wondering about, follow-up on Nicole's question about how can you identify the patient with erosion versus, say, a rupture? Is there any way to stratify that risk based on symptoms, or is OCT absolutely necessary?
At the present time, OCT is absolutely necessary. The previous pathology studies showed erosion is more frequent in young women with smoking hypertension. And we have now database of about 600 patients. In the living patients, we could not confirm those findings. And we are trying to find biomarkers to differentiate patients with plaque erosion from those with plaque rupture. And we are in the process of analyzing those 600 patients to identify exactly what you asked, how we can early on identify those patients with erosion.
Other questions?
All clear?
Clear. Yeah, I think it's an interesting new concept, but of course we need to do more work. We need to have more studies. We have also, and you probably also had patients where we've tried this approach, but it's a low number of patients, and their experience so far is quite limited. So congratulations with this study. So the